Thank you, madam. Thank you very much. Good evening. I thank OXI and all the members of OXI for the wonderful opportunity to be a part of the faculty in revision course. Today's topic, maternal pelvis and fetal skull. The three main components for normal delivery, we all know as the passage, passenger, and the powers. You can, it can be shown as just as a cartoon I have put here. The passage would be the tunnel, and the passenger like a train, and the passenger is the train, and the powers is the uterine contractions. Now, mainly we'll focus on the maternal pelvis and fetal skull and their importance in normal delivery. So what are the, first about the maternal pelvis. The pelvis, we say, is made up of three bones, the innominate, sacrum, and the coccyx. In the innominate bone is again made up of three parts, the ilium, ischium, and the pubis. There are three joints, the sacroiliac, sacrococcygeal, and the symphysiopubic. Now, main thing, the exam, you would be asked, how do you hold the pelvis? Show me the normal anatomy of a pelvis. How do you hold it? So you hold it in such a way that the, I don't know if you can see, so this is how you will hold the pelvis. So that the acetabular, the two acetabular should be facing downward, and the anterior superior iliac spine should be perpendicular with the transverse. Then false pelvis. There is no much obstetric significance, but the true pelvis, there is the main component. Now, boundaries of the pelvis. You can see it in the picture. The boundaries of the pelvis. We start from posterior, the sacral promontory. Then you have the ala of the sacrum, the sacroiliac joint, the iliopectineal line, the iliopectineal eminence, then the upper border of superior suprapubic rami, the pubic tubercles, pubic crest, and the symphysis pubis. Usually they will ask you to show the boundaries of the true pelvis in the exam. And the parts of the pelvis is divided, as we all know, the inlet, cavity, and the outlet. Now, diameters, you have to remember these diameters of the pelvis. The main diameters you should know is the anteroposterior, the transverse, posterior sagittal, oblique, and the sacrocortiloid. Now, first this is the inlet. So, inlet, the important diameter is your transverse diameter. The point you have to remember here is, in the inlet, the transverse diameter is bigger than the anteroposterior. It is approximately 13 to 13.5 centimeters. Now, the AP diameter, anteroposterior diameter, it is smaller than the transverse. The anteroposterior diameter, we usually say the true conjugate, the upper from the sacral promontory to the upper border of the symphysis pubis. In the conjugates, they may ask you, what are the three conjugates? What's the importance? So, obstetric conjugate is the real important conjugate. So, how to know the obstetric conjugate? This from the sacral promontory, the most prominent point on the posterior surface of the symphysis pubis. But what can you measure clinically is the diagonal conjugate. That is from the inferior surface of symphysis pubis to the sacral promontory. Then how to determine the obstetric conjugate? You have to subtract 1 to 1.5 centimeters. Then you will get the obstetric conjugate. It should be at least, the diagonal conjugate should be at least 12 to 12.5. Only then you will get at least 10 centimeters of the obstetric conjugate. Posterior sagittal diameter. This is the diameter of the posterior compartment. So where is it? It is from the transection of the AP and the transverse diameter, the posterior part. So easy to remember is, from the inlet it is 4.25 to 5. Then again cavity will be 5 to 6.25. The outlet is 6.25 to 7.5. So you can see the posterior part of the pelvis is bigger in the outlet compared to the inlet. Then the oblique diameter. Oblique diameter from one sacroiliac joint to the pectineal eminence of the opposite side. But the sacrocortiloid diameter differs from the oblique. Here it is the distance from the sacroiliac joint of one side to the pectineal eminence of the same side. So this is the difference between oblique diameter and sacropodyloid diameter. Now cavity, diameters of the cavity is almost the same because the cavity is circular. It is around 12 to 12.25 centimeters. Outlet. Outlet we have again the anterior part and the posterior part. So pelvic outlet, the important landmarks are the lower part of the symphysis pubis, the pubic arch, and the sacrotuberous and sacrospinous ligaments and the tip of the coccyx. So here you can see the difference in the pelvic outlet. It is totally the reverse of the inlet. Here the anteroposterior diameter is bigger than the transverse. This is 13.5 and the transverse is 11. And the anterior sagittal is around 6 to 7, but the posterior part is much wider. It is 7 to 10 centimeters. Then you have the planes of the pelvis. Actually, this makes two triangles. It's a diamond-shaped space made up of two triangles. Now this grid. So this grid I have put for easy remembrance. So inlet, cavity, outlet. It is easy to remember if you write like this. Anteroposterior, oblique, transverse. 11, 12, 13. So in the inlet, AP is smaller 11, but transverse is bigger 13. The outlet, transverse is smaller 11, but the AP is bigger 13. Cavity is all the same. So 11, 12, 13. If you remember this number, it will be easier to know the diameters of the pelvis. Then planes, if they ask you, show me the planes, you have only the important planes are the cavity, the plane of greatest pelvic dimension, and the plane of the pelvic inlet. So this is pelvic cavity. Why you should know about this? This is the plane where the head undergoes rotation. And pelvic inclination, it is always, it makes an angle of 55 degrees in the standing position. Now important thing, pelvic shapes. Calval molars, pelvic classification of pelvic shapes. Here we have, first is your gynecoid pelvis. It is a female type of pelvis. It is around 50% and the inlet is circular. You can see it is more or less, it is a circular inlet. The android pelvis is around 30%. Here the inlet is heart shaped. So why is it heart shaped? Because the sacral promontory is more prominent. So posteriorly, you get the space is lesser here. Anthropoid pelvis is almost like android pelvis. The cavity is, inlet is oval shape. Here in the anthropoid, it's more oval, but one advantage here is you have a wider subpubic angle. Platypeloid is a flat-shaped pelvis, very wide subpubic angle, and there is say resistance only in the inlet place. If the head negotiates the inlet, delivery is easy in a platypeloid pelvis. But it is less commoner. It is only around 3%. But actually, in humans, the pelvic shape does not stick to one typical type. It is always a mixed type of pelvis. Anterior will be android, posterior will be gynecoid. So anthropogynoid, it will differ like that. So it is usually the mixed type of pelvis which is seen in most women. And pelvimetry. What is pelvimetry? Assessment of the pelvis. So usually what do? We do only clinical pelvimetry. Nowadays we don't do X-ray, CT, MRI is not that much required, and external pelvimetry which was used in those days is not quite common nowadays. So clinical pelvimetry, how do you assess clinically? So assessment is to see if the sacral promontory is prominent and then to measure your conjugate. So I have put this picture to show how the conjugate is measured. So they might ask you in the exam, what are the preliminary steps you have to do? So to measure a conjugate, what should you do? First, you should see to the patient is counseled. You should get her consent and then she should be relaxed and then put her in the dorsal position. The bladder should be empty and then with thorough aseptic conditions, you will put 2 fingers in the vagina, try to reach as high as possible up to the sacral promontory. Gently lift your 2 fingers up to the symphysis pubis, mark the point, take your hand out and measure it. to vibrating again. So 12 to 12.5 to 13 centimeters is ideal. After you subtract 1.5, you should have a diameter which is not less than 11.5 centimeters. So again, another picture to show how diagonal conjugate is measured. Now, how do you assess the pelvis? The 6 S's. So how do you do? First, same thing. Get the patient's consent, ask her to relax, see to the bladder is empty, put her in dorsal position, thorough asepsis. Now do a gentle pelvic examination. Try to reach the sacral promontory. Usually the sacral promontory is not reached in a gynecoid pelvis. If it is reached, probably it is prominent. We have to think about android or anthropoid pelvis. Then the sacral base. Do a, I'll show you in the pelvis. See, once you try to reach like this, and then go around the sacral curvature, sacral base. Then see how you are able to see whether it is curved. Then the side walls, whether the side walls are straight or divergent. We come to the inlet. Then inside sacral spine is not. Then the inlet the diameter is your ischial spine. See, ischial spines are prominent. Then slowly see the subpubic angle, whether the subpubic angle is narrow or wide. It should at least admit 2 fingers easily. So here is quite a wide shape pelvis. Then after you take your hand out, the ischial tuberosity, the space is admit a knuckle. So that is the outlet.
I'm sorry, ma'am. Your voice is a little low, ma'am.
Okay, madam.
Voice little louder, ma'am. Thank you, ma'am. Thank you.
So same thing, the assessment of the pelvis here. Now one more point, they can ask you what is base space of Morris. See, in a very narrow subpubic angle, when the head tries to negotiate itself, you can see the space here. So this space is a base space. Supposing the pubic angle is wider, the head can negotiate little more into the space. So this is more common in android and anthropoid. Android pelvis is when you have a narrow subpubic angle. So how do you say it is an adequate pelvis? So these are the points. The diagonal conjugate should be more than 11.5. The symphysis should be parallel to the sacrum. The sacrum should have been hollow. The side walls must be straight. The ischial spine should be blunt. They should not be prominent. Interspinous diameter should be at least more than 10 centimeters. Sacroiliac is not much like 2 fingers. The subpubic angle should be wide. So that is more than 2 fingers breadth. And the outer, when you take your hand out, bicubic diameter should admit 4 knuckles. And the coccyx should be mobile. So coming to fetal skull. So you have 3 parts of the fetal skull: the face, vault, and the base. Then the bones are the frontal bone, parietal, temporal, and the occipital bone. Fontanelles, anterior and posterior fontanelles. In sutures, frontal sutures.
Sorry, ma'am. Chitrakala. Sorry, ma'am. Ma'am, your voice loud. Chitrakala, என்ன பண்ணோம்?
Ma'am, நம்ம சைடுல இல்ல மேம். மேம் ஓட
மேம் உங்க மைக் பாருங்களேன் மேம்.
லவுட் பண்ணுங்க. ஒரு நிமிஷம் நான் ப்ளூடூத்ல கனெக்ட் பண்ணேன். ரொம்ப லோவா இருக்கு மேடம்.
மேம் இப்ப பெட்டரா இருக்கு மேம். கண்டினியூ பண்ணுங்க மேம். மேம்
ஓகே மேடம். ஓகே ஓகே ஓகே. Okay, what are the significance of the sutures? This is for molding. When you want to know whether there is severe molding, we palpate along the sutures. When there is first degree molding, it is just approximation of sutures, which is normal. And in second degree, it's separable overlap, but worse or a bad diagnosis is overlapping with not separable sutures. Then they will then ask you, show me the areas in the fetal skull. You should know to show the areas. So they will ask you, show me the vertex. So you have to show like this. Always the vertex, you must show like this. This is how you will show. Don't show like this. This is the vertex. No. You should show like this. The vertex is the area bounded by the two parietal eminences, the anterior fontanel and the posterior fontanel. To be more specific, it is the posterior part of the anterior fontanel and the anterior part of the posterior fontanel. You must show like this. Then bro, you will show like this. This is bro presentation. So when there is, the chin should not be seen in bro presentation. Okay, this will be bro presentation. When face presentation, you will show like this. This is how you will show face presentation. If the chin is seen, it is face. If the chin is not seen, it will be bro presentation. And diameters of the fetal skull, everybody knows the biparietal. Three diameters which are the same: biparietal, suboccipitobregmatic, submentobregmatic, 9.5. The occipitofrontal, 11.5, deflexed. Mentovertical, biggest diameter, it occurs in bro presentation, which is 13.5 centimeters. And how was the engaging diameters in a well flexed? I put the picture here. It is circular. In deflex, it is oval. In more deflection, it is more oval. But again, when the head is fully extended, it becomes circular. If there is time, I can show you mechanism of labor. So mechanism, the three important steps are: first is engagement. So engagement of the fetus. Otherwise, I'll rush through this and can I show in the full screen, madam? The full screen. Full screen. Good. So engagement, what is engagement? When the transverse dynamic of the fetal skull enters the pelvic brim, it is engagement. Head is said to be engaged if it is at zero station when you do a pelvic examination, and abdomen when it is only 2/5 palpable. Then you have descent. Where how does descent occur? It increases contraction and syncretism, to and fro motion of the head. Then flexion, it increases contraction. The baby undergoes universal flexion, accommodates itself into the pelvis. And then internal rotation, when the occiput rotates anterior due to the elastic recoil. Crowning is when the head is at +3 and does not receive in between contraction. It is here with the episiotomy. Then the head is borne by extension. And restitution is untwisting of the neck, and lateral flexion and delivery of the body occurs. So this is good luck. Now I will show in the, madam, I will show in the full screen in the video. My PPT is over. So mechanism of labor, how to hold the fetal skull, you should know. See, you should not, in the exam out of tension, you should not drop the fetus down, you should not drop the skull down. So this is how you will hold the fetal skull. So this will be your baby, you will be showing the baby like this. This is fetal skull. Now in the pelvis, what happens? Left occipital transverse. The head first enters in the left occipital transverse diameter, then it descends. So descent, I have written as to and fro rocky movement. So this is the to and fro. Apply descent our body, it needs the to and fro, it negotiates itself. So that is syncretism. It's slightly negative. So anterior asyncretism, posterior asyncretism. It tries to be like this. So as it descends, now there is flexion. So increased flexion occurs. So what happens? The occiput first reaches on the pelvic floor muscle. So once the occiput touches the pelvic floor muscle, there is elastic recoil of the pelvic floor and the occiput rotates anterior. How much does it rotate? It is 45 degrees or otherwise 1/8 of a circle. Now the occiput hitches against the symphysis pubis and the head is borne by extension. So this is, the head is now borne by extension. Now restitution is slight untwisting. Now the baby tries to untwist itself and looks to one side of the maternal thigh. Now slowly the shoulders are born and lateral flexion. The shoulders also, the posterior shoulder descends first and is born, and when the anterior shoulder which is against the symphysis, then the anterior shoulder is also born and the baby slips out. So this is normal occipito-anterior. Sometimes they will ask you, show us the delivery in occipito-posterior. So how to show in occipito-posterior? So we know it is right occipito-posterior is common. So now here the baby is in right side, maternal right side, the occipit is in the posterior compartment. The right occipito-posterior, the head tries to descend. Now, usually the head will, nature will try to make things correct by itself. So it will try to undergo now the same mechanism. It descends, there is flexion, and the occiput touches the levator muscle. Now, but adequate time is taken and the occiput will turn anterior, but this time it will take some time. The rotation is 135 degrees, 45, that is 1/8 and 2/8, so 3/8 of a circle. So 135 degrees it has to rotate. Then similarly again the occipital is against the symphysis and the head is one. So this is delivery in occipito-posterior. Usually it delivers given adequate time, uterine contraction and maternal cooperation. The occiput will try to turn anterior and it will deliver. Of course, in cases when the situation is not so easy, voice not clear. What happens is the occiput will rotate posterior. Now the baby is born as face to uterus. So that it will be born as face to pubis increase and a chin will hits against the symphysis and then the baby is born. So this is more rarer, face to pubis or direct occipito-posterior delivery. And face presentation, low presentation is not possible because the diameter is 13.5 centimeters, mentovertical cannot negotiate into the pelvis. Then you have one more presentation is the face presentation. Only mento anterior will deliver, but mento posterior cannot deliver. So how mento anterior delivers? The same way the mentum is in the left quadrant, left mento anterior, then there is descent, and then similarly the mentum will try to hit against the symphysis pubis and the face is born by extreme flexion and then the head is born. But here there is more of asphyxia and problems because the face, the molding cannot occur in the face and the edema over the face, the baby is difficult, it is difficult to breathe. So these are the points why face presentation baby is more asphyxiated. Mento posterior baby cannot deliver because the head and the chest of the baby trying to negotiate together. When mento posterior, what happens is here there is the posterior, the chest of the shoulders and the chest try to negotiate along with the face. So the baby cannot deliver and it is arrested. So two conditions where mechanism of labor is not possible is mento posterior and bro presentation. Thank you, ma'am. I thank you,
ma'am. Thank you, ma'am. Thank you, ma'am. Ma'am, there's just one question. Is there any relation between waist space and development of BVF?
Yes, you can say when there is obstructed labor. So when the labor is obstructed, so when your waist space is more, so the chance that labor getting obstructed is the incidence is also more, and you can get BVF in the future. Not immediately, BVF can occur in the future.
Thank you, ma'am.
Thank you, madam.
Thank you so much, ma'am.
All the students, good luck. Thank you, ma'am.
Thank you. Thank you so much. We will move on to the next session. It gives me great pleasure to welcome Dr. Sarina Gilbas, Madam is a professor and head of the department OBG at Jubilee Mission Medical College and Hospital. And she needs no introduction to this forum. She always helps us out by the for the revision courses. And she's an excellent teacher. And the way she gently guides and encourages the PGs itself is a treat to watch. We also have Dr. Sailata. She's a professor at Department of OBGYN, Chettinad Hospital and Research Institute, Chennai, and she has 15 years of teaching experience for UGs and PGs. Ma'am, we have three PGs, ma'am. We have Dr. Maheshwari from Teni, Dr. Karunya from Teni. Both of